Good morning, everybody. My name is Avanti, and I am delighted that you are able to join us this morning. Before we get started, I'd like to begin by acknowledging the land that I'm calling in from, and many of you are also joining from today. We are gathered here today on the unceded ancestral occupied homelands of the Musqueam, Squamish, and Tsleil-Waututh nations, recognizing that these nations and peoples are the original stewards and have been the original stewards of these lands since time immemorial. Just to provide a little bit of context and to situate myself, I am a second generation settler of Bengali ancestry. I go by the pronouns she, her, and I am the ICS coordinator. I grew up on the traditional territories of the Anishinaabe, Oji Cree, Dene, Dakota, and Métis peoples on Treaty 1 territory, what we know today as Winnipeg, Manitoba. I am delighted to present Dr. Roseann Larstone. She is the engagement and community lead at Indigenous Health, Northern Health Authority. And before joining Northern Health Authority, Dr. Larstone was with the National Collaborating Center for Indigenous Health, and she is also an adjunct faculty member in the Faculty of Medicine at the University of British Columbia. She brings a particularly unique lens as a researcher, as a Métis scholar, and as someone that I think has a profound understanding of the social determinants of health, which she'll be speaking to today. And so without any further ado, I'm going to pass the floor over to Dr. Larstone. Thank you.
Good morning, everybody. Thank you so much, Avanti, for a wonderful introduction. I'm delighted to be here today for this discussion. So it's my absolute pleasure to be here today on behalf of Dr. Margot Greenwood, who is the Vice President of Indigenous Health, Northern Health, and the academic lead for the National Collaborating Center for Indigenous Health, which is hosted by UNBC. And today we'll be talking about getting to change and addressing cultural safety and anti-Indigenous racism in healthcare. So I'm Roseann Larstone. I'm just going to quickly share this screen. I'm a member of the Manitoba Métis Federation with my ancestral and family roots in the communities of St. Laurent, Oak Point, and Duck Bay, Manitoba. So I'm currently also acting regional director for the Indigenous Health team at the Northern Health Authority in Prince George, British Columbia. So I want to begin today by acknowledging the ancestors and the traditional territories of the Tl'it'le upon whose lands I live, work, and play, and the location from which I'm joining you today. So I just wanted to share, just as a quick disclosure statement, I have no commercial interests in support or delivery of this presentation, and I have no conflicts of interest to disclose either. So in my presentation today, first I want to discuss the social determinants of health and what they mean. I will also talk about determinants relative to First Nations, Inuit, and Métis peoples, including identifying Indigenous specific determinants, and also discuss their intersectional and cross-cutting nature as being critical for understanding the multiple levels at which intervention and change can occur within our health systems. But in addition to some history, we'll also take a more in-depth look at really two big structural determinants, namely colonization and racism, as having the most profound impacts on Indigenous people's health and well-being. I'll then present a model for change that was initially articulated by Dr. Greenwood in 2019, which is currently informing work that's underway in transforming the healthcare system in Northern British Columbia. And then finally, I wanted to share with everyone today some initiatives and knowledge products that are published and also some that are in development. So as we're aware, many factors influence our health and well-being. These factors are often grouped into things like genetics, behaviors, environmental and physical influences, medical care, and also an array of social factors. These factors were underscored in November 1986 through the Ottawa Charter, which highlighted upstream factors and social contexts. The Charter focused on population versus individual interventions, which was a move away from a medical model to a more inclusive model. In 2009, Sir Michael Marmot led a global team that examined the social determinants of health and their impact on individual people's lives. Their report focused on inequities in the contextual realities in which a person lives. The following slides I'll be sharing do a lot to elaborate on these ideas. So the World Health Organization definition of social determinants of health references forces and systems that shape the condition of people's lived realities, including economic policies, social norms, and broader political systems. There are many determinants of health, including the ones listed on this slide. One of the most important considerations, particularly for Indigenous children and youth and family health and well-being, is the family and the community context in which they live. Determinants of well-being such as family income and employment, things like housing, food security, and access to culturally safe health services are a few of the factors to consider. When we're talking about determinants and having these broader conversations, the term equity is a key concept in thinking about the determinants relative to Indigenous peoples. Differences in health outcomes are often described as social inequities, and these are rooted in unequal power relationships and structures across society. For our purposes, we're particularly interested in differences in health status that can be judged as being systematic, unfair, and avoidable. Health equity as a concept means giving patients the care they need when they need it. Or as the Institute of Medicine report stated, health equity means providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, and socioeconomic status. So addressing the determinants of Indigenous people's health means acknowledging that the concept of health extends beyond physical elements to include a range of factors that influence health holistically, including physical, mental, spiritual, and emotional well-being. Indigenous perspectives on health are holistic, and that's really consistent with the social determinants approach that considers the complex and interwoven effects of multiple factors, including income, social status, employment and education, healthy child development, gender, and culture. Mainstream frameworks generally fail to acknowledge that inequalities are often driven by structural or systemic challenges that are often beyond individuals' control. For example, the legacy of colonialism, including removal of children from their families to attend residential schools, and also disproportionately high rates of child welfare apprehensions that continue into the present day, have contributed to high rates of trauma, to loss of parenting skills, and poor health status among Indigenous peoples. So the determinants that you see here go beyond the social to include elements such as spirit and land, for example. So you'll see that this list also looks to the past and the present. So we see things here like colonization, residential schools, self-determination, language and culture, indigeneity, spirituality, and kinship. A determinants of health approach helps us to examine the impacts of structural, systemic, community, and family enablers on the health and well-being of Indigenous people. And all of these determinants taken together bear down on all children and families to varying degrees, depending on the specific context in which they live. For Indigenous peoples, We would say that the causes of the causes of the causes is a more accurate phrase in that it points directly to the colonial experience as the most profound or significant underlying factor for the causes of the causes. This reality and strategies such as residential schools that were used to operationalize a colonial agenda has impacted Indigenous children and families and communities through the generations and is the most profound Indigenous specific determinant of health. So as I alluded to earlier, recognizing the intersectional and cross-cutting nature of determinants is critical for understanding the multiple levels at which intervention and change can occur in healthcare systems, with the effects of these changes reaching through all of the levels. For example, one thing we can point to is that societal shifts at the structural level, which is represented by the outermost layer of the figure in the slide, such as those leading up to the emergence of a new politics of reconciliation that began in the 1990s and continue into the present day. Those have been accompanied by changes in policy, funding, and law. For example, now we can point to the examples of UNDRIP being enshrined in law, both provincially and now federally with the passing of Bill C-15 in June 2021. And all of these directly impact the programs and the services available in First Nations, Inuit, and Métis communities. Availability of and access to culturally safe healthcare environments and services at the community level, in turn, then impacts experiences at the level of the family and individual. So we're now going to look more closely at two Indigenous specific structural determinants that underlie First Nations, Inuit, and Métis people's health, namely colonization and racism. So it's important to understand. I think a lot of people will start with the history. It's so important that we understand our collective history and how relationships have evolved between Indigenous and non-Indigenous peoples in this country in order to really understand the situations in which we're situated and in which we work. Colonization has had, and it continues to have, profound impacts on First Peoples' lived realities, in that the social inequality that's experienced by Indigenous people directly stems from colonization and its processes, including government policies that were created to undermine Indigenous people's family and social organization, and as well as ways of knowing and being. So very fundamental pieces. Some present-day examples include inequitable health service access, inequitable funding of education programs on reserve, and membership controlled outside of self, and so on. I just wanted to share a little bit of history from the Pan American Health Organization's Just Societies report. That report was from 2018, as it is critical for our understanding. So this is a foundational piece. The sustained era of colonialism in the Americas began at the end of the 15th century, and that was led primarily by the Spanish, Portuguese, French, and British. The colonial states deemed themselves as, quote, civilized, and Indigenous peoples and cultures as, quote, savage, in order to legitimize the unlawful taking of lands and resources and the superimposing of Western European culture, institutions, and languages. This dichotomy, and also Spain's interest in asserting land rights over territories that were allegedly discovered by Columbus in his 1492 voyage to the Americas, prompted Pope Alexander VI to issue a papal bull, which then recognized land ownership by Christian peoples, and effectively that negated Indigenous title by declaring the land terra nullius. So in other words, it was owned by nobody. The papal bull in turn gave rise to the doctrine of discovery, which codified the ineligibility of non-Christian peoples to hold title over lands and resources. This doctrine of discovery has subsequently been relied upon by many countries in the Americas, essentially to extinguish or subjugate Indigenous peoples' rights to land and resources. In the Truth and Reconciliation Commission's report, the word truth refers to our past histories. So I'll just ask the question, what is colonization? There's a lot of work around this. One source we pulled from comes from Corey Wilson's Pulling Together Foundations Guide, which noted that in Canada, colonization occurred when a new group of people migrated to North America, took over, and began to control Indigenous peoples. Colonizers imposed their own sets of values, their own cultural values, beliefs, religions, and laws, and make policies that don't favor Indigenous peoples. They seize land and they control resources and access to trade and other pieces. As a result, Indigenous peoples become dependent on colonizers over time. So I just wanted to take a moment here, just so the past tense around colonization is not problematic, but I just wanted to take a moment to note that while the focus here is really on sharing some of the history of Indigenous and non-Indigenous relationships, it's really important that we recognize that colonialism and colonization and their impacts continue into the present day. So on this slide, we see some colonial processes and strategies, along with the intents of the strategies on First Nations, Inuit, and Métis. These strategies impacted all aspects of Indigenous peoples' lives, spanning from governance structures to the education and care of children, to dislocation, to defining individuals outside of themselves. For example, we cite the example of the Indian Act with membership, again, controlled outside of self, as the Act defines who is a status Indian and who is not. And all of these taken together have long-lasting impacts. To cite the In Plain Sight report, colonization was justified through the creation and perpetuation of racist beliefs about the inherent genetic, cultural, and intellectual inferiority of Indigenous peoples. And these racist beliefs were entrenched through two pernicious propositions that gained structural, legal, and policy form. First, that Indigenous people should be treated apart and separate through a segregated health system. And second, that Indigenous peoples could be treated then as objects of the health system for the purposes of research and experimentation, and not as patients for whom the system existed to care. So on this slide, we see some of the long-lasting impacts of the colonial experience. There's an overrepresentation, for example, of Indigenous persons in the Canadian correctional system. Indigenous adults represent approximately 4% of all adults in Canada, yet in 2015-2016, Indigenous adults represented 26% of all admissions to provincial and territorial correctional services. In provincial and territorial sentence custody, 38% were Indigenous women and 26% were Indigenous men. Similarly, Indigenous youth comprised 2% of all adolescents, but in the fiscal year 2014-2015, they accounted for 35% of all youth admitted to correctional services. Regarding other impacts, many Indigenous peoples experience lower levels of education, employment, and income, and all of this results in greater risk of food insecurity. We see this particularly acutely in northern and remote communities. Indigenous children and families are more likely to live in crowded and substandard housing conditions. And Indigenous peoples also suffer higher rates of communicable disease, including COVID-19, HIV/AIDS, and sexually transmitted and blood-borne infections, which are linked to factors such as violence, stigma and discrimination, and also a lack of trust in the healthcare system. So I just wanted to turn our focus now to a second structural determinant of health that continues to impact Indigenous peoples. So we'll talk a little bit about racism in this next section. Racism is both a historical and a contemporary reality with pervasive influence on the lived experiences of First Nations, Inuit, and Métis. Race-based and exclusionary policies at the societal level, like the jurisdictional issues that Jordan's principle was designed to address, impact Indigenous peoples' access to programs and services at the community, family, and individual levels. Exclusion and racism at structural and systemic levels thus then directly impact the health and well-being of Indigenous children and families by impeding access to safe, timely healthcare. So this dynamic is a really important contextual element underlying the system change model that I'll be speaking about shortly. I just wanted to share with you, here's a well-known photograph of a child entering residential school on the left, and then a photograph of the same child after entering the school on the right. The caption speaks for itself, and it really underscores the role of residential schools in seeking to totally assimilate Indigenous peoples through the children into mainstream Canadian society. Just sharing this slide to highlight that racism is alive and well in Canada today. So just sharing a concrete example around this. In Addison Ryan's comments, the writer illustrates both past and still current stereotypes of Indigenous peoples that really sadly underlie many people's thinking about First Nations, Inuit, and Métis. For example, you can see here the writer references an alcoholic, drug-seeking, abusing population, each one of these being long-lasting beliefs. And further, the notion of Indigenous people getting things for free, including housing and education, is another common and widespread fallacy. So just to take apart the construct of racism itself a bit more, it really is a form of discrimination, and it's a social construct. Indigenous peoples' experiences of racism in different systems, including the health system, education, and justice, stem from our shared colonial past, and that's really the basis of everything. As we've already touched on, colonialism was justified through the widespread perpetuation of racist narratives about the inherent deficiencies of Indigenous peoples. And over time, racist attitudes and beliefs became entrenched, really embedded within the overarching policies, systems, and structures, which continue to be self-preserving into the present day. It's important to note as well that really before the 1600s, people in Europe identified themselves primarily on the basis of their language and religion, and not by race. Racism was used to justify colonization, and it continues to marginalize Indigenous peoples in their own lands. So it can take many forms as well, and it can be built right into structures and systems. And in other cases, it can be seen within interpersonal interactions. Brenda Gunn, back in 2017, wrote that racism, including systemic racism within the healthcare system, is a significant contributor to Indigenous peoples' lowered health outcomes. Racism isn't limited to interpersonal issues during the provision of health services. Structural racism is evident throughout the Canadian healthcare system. It exists in the policies and the practices of the health system and within other sectors, and these all have profound negative effects on access to healthcare and also health disparities. So I just wanted to now begin. That's a lot of background, it's a lot of context. I just wanted to now start to pull all of this together, just simply recognizing that determinants of health is a huge topic, and it can be overwhelming to folks when we start to think about what it is that we can do as individuals within healthcare systems to create change. The model presented here is meant to help us to situate the determinants and ourselves in this work, and it's really addressing the determinants of health that underlies change. Determinants can be categorized as big structural change agents. For example, as I've referred to previously, we have things like legislation, high-level policy agreements, human rights instruments. And so we can point to things like the Canada Health Act, the Indian Act, and the UN Declaration on the Rights of Indigenous Peoples, and other new pieces of law. We also have systemic change agents at the organizational level, which can then include policy within a health authority, for example, or perhaps a change in a clinical practice guideline. Service delivery change is the level where we modify our individual interactions and practices. The structural and systemic change determinants are meant in the end to enable good practice. In other words, to support all of us in providing the best possible care. So I'm just going to now shift gears a little bit and speak to some change pieces that are currently underway within the Northern Health Authority. Northern Health's commitment to providing culturally safe healthcare, and really this is the case for all of the health authorities in BC. This commitment is grounded or situated in a broader social and political context that acknowledges the realities of Indigenous peoples in British Columbia. We're committed to this through a formal agreement. So we have the Declaration of Commitment to Cultural Safety and Humility in Health Services Delivery for First Nations and Aboriginal Peoples in BC, which was signed. There are multiple versions of this declaration. So the one in 2015 was signed by the CEOs of all health authorities, the Ministry of Health, and the First Nations Health Authority. The TRC's 94 calls to action, which were also released in 2015, brought national attention to health inequities experienced by Indigenous peoples. As we know, several of the calls are focused on health, and many of them advocate for the education of non-Indigenous people in Canada to learn about issues, including the history of Indigenous peoples, Indigenous rights and title, treaty rights, the history of colonization and residential schools, and the UN Declaration on the Rights of Indigenous Peoples. In 2020, allegations of racism in the BC healthcare system and the subsequent In Plain Sight report that was released in November of last year, which documented the independent review into those allegations, brought renewed attention to the issue of culturally safe healthcare. And as we all know, work is actively ongoing and underway to ensure that the recommendations arising from the report are implemented or integrated into health systems throughout BC. So just as a very brief refresher, although I'm sure most people will be familiar with the report, the 24 recommendations arising from the In Plain Sight report focus broadly on systems, behaviors, and beliefs. Northern Health currently has activities in 11 of those published recommendations, and bearing in mind that many of the suggestions or recommendations, were directed towards the Ministry of Health. In terms of Northern Health response, recommendation 20, for example, calls for a renewed approach to training for health workers. And as I'm just going to talk about in a few moments, Indigenous Health is developing a series of learning modules on respectful relationships and culturally safe healthcare. We're also working with physician groups to support specific education opportunities in the organization. Another piece we're working to engage all portfolios to ensure that recommendations from the report are integrated into the organization's change agenda. To support this work of facilitating the overall goal of health system change, we produced an overarching strategic document for the organization. So we have the Making It Real, Cultural Safety and Northern Health Framework. This whole document essentially began as a reflection on the work of the Indigenous Health team. And then with the release or publication of the In Plain Sight report last year, the review for the Indigenous Health team was then really broadened out to take a more systematic look across the whole organization. And while there were many initiatives and projects underway that were already being undertaken, this really gave us a more systematic look at how cultural safety work fit within Northern Health's overall goals and strategic plan. So the framework, in essence, as you can see, is an organization-wide inclusion plan that's led by Northern Health senior leadership alongside the Indigenous Health team. And it's really intended to create systemic change that enables culturally safe healthcare service delivery. I just wanted to share with you some knowledge products that have been produced by the Indigenous Health team, Northern Health. This particular poster was published in 2017. It's up on our website. And it's the third in a series of posters that support the cultural safety video that I am just going to open right now.
Indigenous peoples thrived on the lands of present-day Canada for thousands of years. About 500 years ago, Europeans began to arrive. By the 1900s, an explicit colonial agenda to control and assimilate Indigenous peoples was in place. The impacts of this are still felt today and show up as a larger burden of ill health, loss of language and culture, dislocation, and marginalization. This history is part of Canada, and we all share a responsibility for healing relationships. How do we do this? Creating an environment of cultural safety in healthcare settings is one step toward healing this relationship. Cultural safety is achieved when people of diverse cultural and ethnic backgrounds feel respected and safe from discrimination. At Northern Health, our values include empathy, respect, collaboration, and innovation. When we put these values in action, we strive to honor diversity, genuinely care, and build trust through understanding. Cultural safety grows when these values are applied to the context of cultural differences. How can we do this? By developing our cultural awareness, sensitivity, and competency through cultural humility. Let's take a look at the meaning of each of these terms. Cultural humility is a lifelong journey of self-evaluation, reflection, and learning to deepen our understanding of how our life experiences influence how we understand and interact with others. The skills of self-reflection and assessment carry us along a path of understanding and change. The journey often starts with cultural awareness, recognizing that differences and similarities exist between cultures. Learning about the histories that impact Indigenous peoples in Canada is an important part of developing cultural awareness. Cultural sensitivity grows when we start to see the influences of our own culture and acknowledge that we have biases. This can be an eye-opening experience, and it may take courage and humility to walk this path. Cultural sensitivity is not about treating everyone the same. With cultural awareness and sensitivity comes a responsibility to act respectfully. Cultural competency is about developing practical skills for interacting in respectful ways with people who are different from us. It's about reducing the number of assumptions we make about people based on our biases. Cultural competency does not require us to become experts in cultures different from our own. Cultural safety improves as we proceed along this path of self-reflection and learning. The goal of culturally safe healthcare is that people feel respected and safe from discrimination when they access health services. As healthcare practitioners and service providers, we have an opportunity and a responsibility to provide the best quality care possible to all individuals. And this involves developing our cultural competence through humility. Along this journey, we begin to understand and appreciate the gifts that each of us brings to the table. Together, we can work to ensure that everyone is able to maintain their dignity when they are seeking care and at their most vulnerable. We can, as individuals and as organizations, foster trusting and respectful relationships between Indigenous and non-Indigenous people and communities. So our journey begins.
I see that many of the ideas that were presented in the video reflect those that appear in the In Plain Sight report. So I just want to share some other products produced by Indigenous Health, Northern Health, supporting system change. We've also produced a self-assessment tool to support staff to build cultural safety and humility into any policy, initiative, or clinical practice guideline. So in late 2020, early 2021, we've rolled out the Northern Health Indigenous Health Cultural Safety and System Change Assessment Tool. This tool was developed collaboratively over the last 2.5 years, and its purpose is really to support Northern Health staff and professionals to be inclusive and respectful of Indigenous peoples and communities in the development and implementation of healthcare initiatives. And ultimately, the tool is intended to support culturally safe health services and health outcomes for Indigenous peoples across the North. And then just briefly, at the heart of this tool are 4 thematic decision-making trees with prompts to guide end consumers through a series of steps around ensuring cultural safety is embedded within initiatives. The decision-making trees are engaging Indigenous peoples, addressing health equity through access, ensuring Indigenous inclusion, and informing evaluation. So just a slide reminding us that the principles of cultural safety and cultural humility assume that learning is ongoing and that it continues throughout our personal and professional lives. So next, to address, as I mentioned earlier, to address recommendation 20 from the In Plain Sight report, Dr. Greenwood and I, with support from the Indigenous Health team and with support from staff at the National Collaborating Center for Indigenous Health, have recently developed learning modules for the organization which focus on understanding and enacting cultural safety in the context of respectful relationships. The curriculum is a partnered piece between Northern Health and the NCCIH, which we're aiming to make available for all Northern Health employees free of cost. And we're currently driving towards a September launch for this learning series. We have 4 modules within this curriculum, and each module is divided into 4 or more sessions, each of about 45 to 90 minutes in duration. So really, in terms of this curriculum, we conceptualize this as really being for everybody. The first iteration we've just completed drafts on and are piloting now was written or targeted towards clinical staff. But we do absolutely recognize that adaptations will be needed to make the learning modules accessible for all employee groups across the organization. For example, accessible to volunteers, to food services staff, and to housekeeping staff. And so really making content accessible. So the training is really about learners enhancing their current practice and really building on what they already know and what they're already doing well. And at the same time, this curriculum really challenges people to question their own taken for granted ways of understanding and practice in order to support change. The curriculum also offers learners an opportunity to gain awareness and understanding of the relationship between colonialism and racism, and how this relationship helps to support self-perpetuating and inequitable colonial systems. And finally, the training provides tools and strategies so that participants are equipped to really understand their own role in health service delivery change, and also to become agents of change. These tools and strategies include things like communication and critical self-reflection skills, awareness and understanding of the multiple levels at which change and transformation can occur within health systems. Also, we ask people to begin to identify barriers and opportunities for change. And there are pieces around building awareness and understanding of trauma and compassionate informed care approaches relative to Indigenous people. I just also wanted to briefly share an outline of the curriculum so that folks have a sense of the content and also the approach that we adopted. The modules overall were written from a very positive place in that we recognize that we all have bias, we all carry prejudice. This is a part of being human. And part of this comes from our socialization. So we really do take these ideas apart and we unpack them so that learners can come to understand and also come to self-reflective practice. One of the major goals was really to bring this learning to the ground for people, and also to provide concrete practical tools and skills that will support respectful relationships, and also respectful interactions, and ensure culturally safe healthcare settings and culturally safe health service delivery. So in Module 1, as we see, we introduced the concept of cultural safety. And this is really just a taster or an overview of the major concepts that will be presented across the curriculum. And really a highlight of this particular module, I'm in the process of doing this piece now. A highlight is the inclusion of a series of videos featuring Northern Health voices that really bring the context of Northern realities and information about Indigenous peoples of the North to life. So we do present an overview of the North, including information and content on the 55 First Nations, 17 linguistic groups, and 10 Métis chartered communities in the North, in order to equip learners with increased awareness and understanding of the Indigenous peoples whom we serve in Northern Health. In Module 2, there's quite a lot of content around Canada's colonial past and present, and how colonial policies, systems, and legislation continue to impact Indigenous people's health in the present day. So we discuss things, present things like colonial tools, including the Indian residential schools, Indian hospitals, Indian Act, the reserve system, and the 60 scoop and the millennial scoop. Learners need to really understand the history of Indigenous and non-Indigenous relationships in order to understand how we got to where we are today. We also introduce in this module the social determinants of health, of Indigenous people's health, including the two big structural pieces that I presented earlier. And all of this is to support healthcare professionals in addressing health inequities. So moving to Module 3, within that particular module, and indeed within the whole curriculum, there is a heavy emphasis on critical self-reflection and being aware of what are my biases and assumptions. And this module also examines the concept of systemic racism and other forms of racism. Then finally, Module 4 is all about getting to change. So there's a lot of work around communication pieces, really practical strategies around particular forms of communication skills, and also identifying opportunities and barriers for change at the structural, the systems, and individual levels that I've talked about, and also compassion-informed and trauma-informed care and Indigenous people. And it really builds on that critical self-reflection piece, again, getting this on the ground for folks. So I think overall in this work, like we're really asking practitioners to really look at themselves, and indeed we're asking organizations to look at themselves as well. We're looking at how our own biases can influence our practice and our being in the world. So we did give much consideration to what do nurses and clinical staff, physicians, housekeepers, and all employee groups need to know, as we intended to make this learning practical and specific to their worlds. Okay, just a quick slide to highlight other resources supporting cultural safety that have been produced by Indigenous Health, Northern Health. We have a series of products, including fact sheets, including animated videos and booklets and reports, and all of these are available at our website. So I just wanted to highlight work continues every single day. We have resources coming out all the time. So I would encourage you to visit our website to access some of these. And also I would point folks to our partners at the National Collaborating Center for Indigenous Health, the NCCIH, as they have a wealth of resources around cultural safety and Indigenous people, and indeed all topics across the spectrum of public health. Thank you so much.
Thank you so much, Dr. Larstone. The way that you've presented this information is a lot, I guess will provide us with a lot to reflect upon. And I found that video to be particularly helpful. I think as folks that work in healthcare, we can all think about the way that we approach our practice and think about some of the tangible ways in which we can make our organizations more culturally safe. One of the questions that came up was around the modules, and we have a question of whether or not these modules are available to folks outside of Northern Health Authority. Is there any scope for people to sign up at cost, or is it right now intended for Northern Health employees?
Oh, goodness, thank you so much for the question, Avanti. It's a really great question. Thanks to those who posed that and similar questions. Yeah, I can tell you there has been tremendous interest in this curriculum and when this is going to be released, both within our own health authority, and much more broadly than that. I know that there's been some national interest as well. I spoke with the Canadian Pediatric Society last month around this as well. So there's incredible interest and really a desire on the part of practitioners and healthcare staff to really learn about this work. And I think a lot of the messaging is getting out there that this is a very important piece in changing health systems. Just to answer the question specifically, we are aiming to launch this curriculum within Northern Health, make that available initially to the approximately 8,000 employees within this One Health Authority. We're really driving hard towards a September launch, and that will be available free of cost for Northern Health staff on the UNBC Continuing Studies website, so it's completely free. I think we're going to have to see how it goes. It's absolutely within the realm of possibility that this curriculum will be available more broadly in future. I think that we're going to have to keep you posted on that, and certainly, just to respond to that interest around it, we can absolutely see this going more broadly, but we're starting with Northern Health.
Yeah.
Oh, I'm sorry. Just to build on that. Sorry, Avanti, just to answer the second part of the question, which I just remembered. The course, when it would be offered, it would be made freely available to folks. So folks wouldn't need to, register with cost or anything like that.
Oh, that's really good to hear. I know that each health authority is approaching this work differently, and to see the modules and what's covered in each modules is, I think, particularly insightful. I appreciate the modules that were covering the realities of living in the North, and I was wondering if you could speak a little bit more to that. So in that module, when folks are going to be exposed to Northern realities, what kinds of things come up?
Okay, no, that's a great question. Thank you for that. Really, yeah, exactly. Because we initially wrote the curriculum for Northern Health staff. We thought, okay, there should be, and correctly, should be emphasis in the beginning on the vast and complex geographical, political, and social landscapes that of Northern British Columbia. And so what we really did was present on the one hand the content around who are the First Nations in Northern British Columbia, as there are 55 First Nations community across our three health service delivery areas across the Northwest, the Northern Interior, including Prince George, and then the Northeast. And so there's such the broad, huge diversity within that. And as I mentioned before, the 17 linguistic groups, 10 Métis chartered communities. And so we present, statistics and tables around those sorts of things. But also we thought, what an impactful piece it would be if we had Indigenous leaders come to speak to some of these pieces as well. So we have engaged folks like Chief Wilf Adam to speak to, who are the First Nations of Northern British Columbia, talk a bit about governance within that, talk about the different regions. Yesterday I spoke with Barb Ward Burkett, who provided a wonderful video on the friendship centers across Northern British Columbia. She has such a rich depth of experience and knowledge of those centers, as she's worked in the friendship center movement for the past 49 years, I think 29 of those being in Prince George. So we're extremely fortunate to have had her join to provide her knowledge around that. We've had Representative Katina Pollard from Métis Nation BC to share her wisdom and her knowledge around who are the Métis people, a little bit of the history of Métis people in British Columbia, and talk about the chartered communities across the northern region. Let's see, we have had Darlene McIntosh provide a beautiful welcome to the territory and opening prayer to open the learning series as well. So these are just some of the pieces that we're just so excited about. Like, we can see this now really coming together and coming alive, I think, for folks, as we're just bringing more of these voices in. Oh, and yesterday, as one more example, we had Tina Fraser, who's a Maori scholar who works at UNBC's faculty. She's taught nurses for the past 15 years in the area of cultural safety and cultural humility. And so we thought, who better to speak to this in a little overview video to add to the content. And so all of these overview pieces that I really think do bring these pieces to life far more effectively and impactfully than a table on a piece of paper can.
Yeah, absolutely. I think just what you're mentioning in terms of the diversity of Indigenous people in the North is a critical component. When we have a better understanding of the diversity in specific regions, I think that can really help in terms of how folks are approaching this work. And then you also mentioned just the vastness of the land. So that, I think, is another important component, knowing that for some people to be able to access healthcare services is often a huge barrier. And so how do we make the services more accessible is something that I think we need to think about, and also figure out a way in which we can provide healthcare services so that folks are able to actually access services more readily. And another question that I had was just concerning attitudinal shifts. I know that you were speaking earlier to reconciliation and UNDRIP, as well as Bill C-15. Has there been any studies that have looked at how healthcare practitioners are approaching care with respect to Indigenous patients? I'm wondering if there has been any recent research post the In Plain Sight report.
Oh, that's an excellent question, Avanti. I think, yeah, no, I should really go to the literature on that one. Yeah, as we've been so immersed in developing this curriculum piece, we continue to see research. For an example, there was a recent study co-authored by Dr. Nadine Caron, documenting worst post-surgical outcomes for Indigenous peoples. And really, again, highlighting those health inequities and disparities and referencing, again, determinants and context that we've been discussing here. No, that's an excellent question around, is there current research following in plain sight? That would have to be one of those things as we look to perhaps revise or update pieces of curriculum that we could incorporate. But at the present time, I'm not aware of such research. That's not to say it doesn't exist, but I don't know it off the top of my head.
I'm familiar with Dr. Caron's work, and I think the reason why I was particularly thinking about that is I think it's sometimes easy to understand or think that we understand racism at a structural or institutional level, but recognizing that we may be contributing to racism is something that I know for myself I have a challenge with. But I think first and foremost, it's recognizing that we all have biases, as you've mentioned, and it was shared in the video, and then recognizing when those biases are impacting our interactions and how we can perhaps think about the way in which we approach interpersonal relations, and constantly doing that work of self-reflection is really important.
No, absolutely. And as we say, you know, we certainly did not, the curriculum itself is not punitive. Again, I think it's written from a very positive place, and just owning and recognizing just the fact that we're socialized in particular ways. We were brought in, you know, we were raised in particular societies and cultural traditions. And what do we bring to every interaction? Like what are our needs, our prior experiences, you know, our expectations or needs or this kind of thing. What are we hoping to achieve in interactions? And we're also interacting at the same time. We're always in interaction with other cultures. And so just being aware, just raising that awareness and understanding of what it is that we're bringing to the interaction, and then developing or just building on skills. I think a lot of people have skills in these areas around communication, including like active listening and empathic listening. You know, and these sorts of things, I just think that we're just helping folks to build on what they're already doing well, and just to build that awareness and understanding again. And I'll just come back to your point, Avanti, like no one says, Margot says this all the time, and it's so accurate, you know, when folks are going through their training, when they're, you know, in medical school and so on, no one says, you know, oh, by the way, you're signing up to work within an inherently racist colonial system. Like, do you know what I mean? So I think certainly we are seeking to help to build that awareness through this learning series. And so hopefully that will be one of those change pieces that will be, you know, not just offered here and have impact here, but also much more broadly. I think that's the vision.
The fact that we have folks like yourself and Dr. Greenwood that are helping to really lead this work, I find very encouraging. And I think also knowing that this is part of medical education is also important. But another thing that you had mentioned that is, I think that folks need to consider is that this work isn't just this work doesn't just rest on the shoulders of healthcare practitioners. Every healthcare employee needs to take ownership for their behaviors, for their implicit biases, and think about how, again, we can work differently and think about how we can make our systems more equitable. Again, a lot of this work, it seems very abstract at first, but I think through these particular learning modules that you've developed, being able to identify where we have those gaps and then thinking about how we can change our actions is going to be really helpful for being able to establish safer spaces.
No, absolutely, Avanti. Exactly. I mean, it's absolutely the truth. The work around cultural safety is really for everybody. Like, we're just bringing this to the ground for folks. I do think, well, I'll just share briefly, although we're still very much drafting these and they're in development, we're working towards developing some common competencies around this. So we were talking earlier about the behaviors and skills and attitudes, but really it's now thinking through, and not just us, but I think just across the province, like what would the set of core competencies or what we would call key learnings need to be? Like what would we expect to see in terms of actions, like behaviors and skills? Yes, and indeed, within attitudes, although that is harder to get at, what would we expect to be seeing from our healthcare professionals and staff within our organizations in the delivery of culturally safe healthcare, not the services and the environments and the interactions? And so we're putting thought to that as well, just as another piece to, I would say, supplement and drive this work forward.
It's challenging to be able to measure or evaluate where we are with respect to cultural safety, but I think having that type of tool, as you're mentioning, is going to be a starting point for us to be able to see again where particular teams or the whole health authority is in terms of we can't ever fully achieve cultural safety, but creating more culturally safe spaces. One question that has come into the chat box is asking of where we can access trauma-informed practice and compassion-informed care that you had mentioned earlier. Are there any resources that you can recommend, Dr. Larstone?
Oh yeah, no, absolutely. It's a fantastic question. Thanks for that. We are engaging Dr. Linda O'Neill, who's at UNBC, to participate in creating a little video around compassion-informed care for this learning series. But for right now, what is available, I do know that Pat McCocus and Dr. Greenwood have spoken beautifully about this. There is a webinar available on the NCCIH's website. I would highly recommend folks to access that piece. And I can also forward, I just don't have the hyperlinks right in front of me, but there are other videos that we've selected for inclusion in the curriculum that we would also recommend people view as convenient. But certainly start with the NCCIH around trauma-informed, compassionate-informed. It's an excellent, excellent piece.
I've seen that webinar and it is excellent. We can include that in our post-webinar email so that folks have a chance to view that at their leisure. At this time, I would like to thank you so much, Dr. Larstone, for sharing your insights, knowledge, and gifts with us this morning. I also want to thank our ASL interpreters, Lily and Jillian. And finally, a big shout out to the ICS team, Tristan and Nisha, for continuing to do that important and critical background work. I hope that everybody has a wonderful day, and bye for now. Thank you.